Good evening, everyone. My name is Dr. Amar Swali, and I am a consultant physician and nephrologist working with Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. And it is my pleasure to invite you to Series 120 of the Africa Healthcare Network Fireside Chats. It is also my pleasure to introduce our speaker this evening, Dr. Felix Jebasingh. And Dr. Felix Jebasingh is a professor in endocrinology at the Department of Endocrinology, Diabetes, and Metabolism at the Christian Medical College, Vellore, and the CMC Vellore Chittoor campus in India. He is managing the high-risk gestational diabetes mellitus clinic in CMC Vellore town campus till date, and is actively involved in research activities that are associated with mothers with gestational diabetes. He is actively involved in basic science studies on body composition and dynamic studies related to mothers with gestational diabetes and in patients with lean phenotype diabetes mellitus. Moreover, he is also an active member in the islet cell transplantation consortium at CMC Vellore. He is also spearheading the once-weekly integrated diabetic foot clinic, along with the general surgery, vascular surgery, physical medicine, rehabilitation, and physiotherapy, as well as the prosthetics and orthotics. His other research interest is on finding the pathogenesis of diabetic foot, especially on the Charcot's foot. He also developed a newer offloading maneuver for diabetes-related plantar foot ulcers that is soon to be patented. In collaboration with the Department of Biomedical Engineering at CMC Vellore, he has given ideas and clinical inputs in developing a new software for measuring the size of the diabetic foot ulcer, and also a modified biothesiometer that are in the stage of clinical validation. He has pioneered the endocrinology facility at the CMC Vellore Chittoor campus in Andhra Pradesh since January 2017, and has also started an integrated diabetic foot clinic along with the Department of Physical Medicine and Rehabilitation and Prosthetics and Orthotics since June 2020 in CMC Vellore Chittoor campus, Andhra Pradesh. He has 70 publications in various national and international journals and has written 20 chapters in various endocrine books, and is also editor of 2 Atlas of Endocrine and a comprehensive guide for clinicians, the first edition. He is part of 24 multinational clinical trials at the level of principal investigator or co-investigator. He has also obtained funding from the Indian Council of Medical Research and has developed a unique network with the H. Gordon Roberts Hospital in northeastern India, and has initiated an epidemiological survey on NCDs, as well as implementation of preventive strategies of NCDs among high-risk individuals. He is involved in epidemiological research with the 50-year-old Vellore birth cohort, the VBC, which is one of the oldest cohorts in the Tamil-speaking Dravidian origin, and obtaining international funding. He is also a recipient of the Gold Medal of Endocrinology Super Specialty exams conducted by the Tamil Nadu Dr. MGR Medical University in August 2016, and he has also acquired a postgraduate diploma degree in medical lawsuit and ethics. This evening, he will be speaking to us on how to care for foot ulcers in our population with diabetic kidney disease. And with that, Dr. Felix, I welcome you. The floor is all yours.
Yeah, good evening and warm welcome to all the audience here. And I thank Dr. Amar for the brief introduction. And I thank all the members who invited me to be here in the forum to discuss about this topic, which many times I always feel this is neglected, or sometimes it's overlooked because it's not a very fancy disease as such compared to the other disorder. So I will be probably focusing more about the diabetic foot, but the topic mentions a patient with diabetes, foot and kidney disease. But if you look at patients with diabetic kidney disease, or maybe having diabetes without any kidney disease, or maybe having a mild kidney disease, the foot actually problems is not much of a difference. But I'll be showing a couple of slides about how there is a major parallel line runs between the diabetic foot as well as kidney disease, which is actually have a lot of overlap and which actually needs to be looked at in a greater detail. And so if anybody wants to interrupt me in between, I'm happy to clarify, and we can have a question and answer session a little later on. So my talk will be for next 40 minutes. Yeah, so this gentleman in my right side and the left side are both the same. It's Dr. Paul Brand, who was working in CMC Vellore for many years, and he is one of the pioneer in terms of developing something called total contact cost. And interestingly, this gentleman has never actually patented that. And what we are using, the so-called total contact cost, is one of the valuable therapy for diabetic foot in whole world, because he never patented it. So if you would have patented it, probably CMC will be one of the hospital with millions of dollars pouring in. But thanks to this gentleman who actually never patented it, and he has written one of the book. Actually, I always love to speak about it, because the gift of pain. Because we all go to a hospital probably only when we have a pain, and otherwise we are not going to go for any other problems. Because if I have a tummy pain, I go to hospital. But if there is something grows inside my tummy and I never cause pain, I'm not going to go to the hospital. So the gift of pain is generally lost in patients with diabetic foot. And we all know that the peripheral neuropathy is the biggest problem in diabetes per se. And almost 50% of the patients with diabetes, when they have been diagnosed with hyperglycemia for the first time, have some degree of neuropathy. That means that this gift of pain is lost. So what happens is they actually never complain to us. It's our duty to look into the feet and take action whenever it's required. So I talked about a couple of slides, but when we looked at ulcer and kidney disease, this is one of the beautiful study was done in southern part of India by Dr. Vishwanathan Mohan. You can actually, it's very interesting study where they actually took patients with renal disease, and then where they had a diabetic foot ulcer, had an infection, and the opposite arm, when they looked at patient with diabetes and never did not have a foot ulcer, they found that patient who had a diabetic foot ulcer disease, when they get a diabetic foot infection, they had a very significant reduction in the GFR, and actually never came back to their baseline, or never came back to the normal. So they actually finally mentioned that the diabetic foot patients, if they have a CKD, they die very faster than the patient who never had infection, though they have CKD. So I'll just go to a couple of cases and discuss what exactly is I'm talking about. This is a gentleman who has a mild kidney disease. We can say that he has stage 4 kidney disease and has a peripheral neuropathy, obviously, because he has 20 years diabetes, and he was never diagnosed to have any macrovascular complication, and he never had any foot ulcer. So this is gentleman walks to your clinic, and as a nephrologist or a physician, you will be looking at the every aspect: diabetes, the creatinine, and metabolic bone disease, etc. But it's important to look at their feet, because as we mentioned, that if somebody has a CKD and has an infection in their foot ulcer, which is probably subclinical, or maybe having a sepsis, which is probably detected a little bit later, and probably which could be been prevented, they actually end up having a rapid worsening of the renal failure, and their life expectancy comes down. That's what it has been told. So if we look at, I'm not going to make it interactive here, but I'm just trying to make you think what exactly is that this gentleman has, and how we can actually probably prevent him from getting a foot ulcer. This gentleman never had foot ulcer, but when he come for a diabetes treatment as well as CKD, it is you can see that this gentleman has the left foot has a hallux valgus, and also we can see that there is a slight overriding of the first toe, that's a greater toe, and the second toe. In the right side, we can see there are quite a bit of a clawing in the other toes, and wherein we can say there is abnormal pressure in the forefoot. So this actually a very so-called pre-ulcerative state, which is actually should be prevented. So it comes under a primary prevention for a foot ulcer, because he never had a foot ulcer. So what exactly happened is, when we walk, we have a lot of stance where we have heel off, heel strike, then have a flat foot, and then late flat foot and a toe off. This is a normal way how we walk when we don't have any deformity in our lower limb. And what happens is, when the patient has clawing or malato, which I'll be showing a few pictures in the later part, where what's happening is the same stance and the swing phase goes, But unfortunately, the pressure is more in the forefoot, and that causes actually a multiple callosity in the tip of the toes, and probably even some degree of friction in the dorsal aspect because of their footwear, which could be tight or which could be having a straps. So it causes actually multiple abrasions, and they never complain to us saying that there is some degree of infection, some degree of ulcer which forms, and it continue to stay there, and then it infect, and then the other worsening of renal function sets in. So it's that's how it happens. And the other thing what is very important is not only the vertical force, it is actually the horizontal force also happens because when they walk, they slides inside the footwear. And moreover, when there is a sliding of slip their foot inside the footwear, there's actually a increase in the temperature. But unfortunately, we all know that there is motor neuropathy, sensory neuropathy, as well as autonomic neuropathy. So all put together, our preventive mechanism is such a way that it maintains the temperature all across that feet. But unfortunately, this whole system of maintaining the temperature goes off, and there is an abnormal pressure in one area, and the temperature goes high, and the patient never actually experiences any degree of pain. But if we all have an opportunity to rub our feet in the floor for next 10 minutes, we will never rub it after 10 minutes, because we start experiencing some degree of pain or temperature increase in the temperature in a couple of areas, and our preventive mechanism will tells us that we are actually experiencing pain or temperature which is almost concordant, and we end up stop that. But unfortunately, the patient with diabetic foot, and also maybe in patient with chronic kidney disease, we can say that they will be having almost equal amount of neuropathy in their feet as well, because if you do a monofilament or a biaesthesiometer, which is nothing but a tuning fork which is graded, we can actually pick up saying that they have almost equal number of, let's say 100 patients with CKD because of diabetes, they all 100% will be having neuropathy. So it's very important to pick the diabetic foot ulcer or maybe a pre-ulcerative state at a much earlier stage. So when we talk about pre-ulcerative state, this is actually very well-known phenomenon all across our textbook, but they many times they don't highlight in such a way that it is actually a greater problem, because we are in an era of preventive medicine. We talk about preventing a non-communicable diseases. We talk about prevention of diabetes, hypertension, ischemic heart disease, strokes, and cancers, asthma, and all are non-communicable diseases. But there are people, quite a bit of people who already has diabetes, hypertension, and their non-communicable diseases. So what about their problems, especially in patients with diabetes? We need to remember that there are a lot and lots of pre-ulcerative state, which is actually is being a higher prevalence. Almost 60 to 70% of patients will have that some degree of one of this disorder in their feet. Let's say the patient who has come to, I just shown few minutes back, the patient with diabetes and CKD who walks into the clinic, and we can see they have mallet-toe. So that one of the thing is already tick, and second thing is he has he has hallus valgus in the left foot. So with that, because of that, there is a bunion happening. So it's very, very important to take care of all these problems. And I'm just going to highlight that these are much important. And most of us will know how we need to probably treat this, because if, let's say, intertigo is nothing but web space where you can see a small fungal infections. And if suppose this is not being treated, let's say we're not given any local antifungal, what happens is that actually can develop into this. This is not a sequential picture, but this is another patient's picture, which is to correlate that they can have a smaller ulcer around that and probably develop into an amputation. So it's very important to look at the web space, whatever the duration of diabetes. It's very important. Other thing is, I said mallet-toe or hammer toe, where I said that when the patient continuously walk with their tip of the toes, because it's all clawed. So when we all walk like this, they walk like this. So when they walk like this, there is abnormal pressure in the tip. So we can see here this lady, if you can closely look at, there is a major degree of callosity which is formed here. And this callosity probably leads on to a bleed within, and then probably end up having amputation. So, but unfortunately, because the pain is lost, they don't actually feel the pain. So they walk continuously with this tip of the toes being hammered in the lower limb and then continuously walk. So this is just an expanded view of or zoomed view of the, you can see there are a couple of callosity in the both the toes. Okay. And this is all various type of callosities which can predispose into foot ulcer. And this gentleman actually, if there is a occupational hazard is one of the, not occupational hazard, it's one of the occupational related problem where the patient sits cross-legged when they sit in their accounts department. He sits in the cross legs. So where there is actually, you can see that the lateral malleus and the lateral part of the little toe continuously gets in contact with the floor, and he has callosity. And remember that these two areas as skin, fascia, and the bone, and probably a thin layer of muscle. So if that is both breached, the patient end up having an osteomyelitis because they don't know have pain. They just continuously sit. So it's a simple idea is tell this patient to have a small stool and sit in the stool and keep the legs straight, not as a cross leg. A simple maneuvers actually can prevent a foot ulcer as well as probably a future amputation. Okay, this is the lady I showed few minutes back where there is intertigo in the ring, but this lady did not take care of herself. So you can see that the small area of already a cellulitis has set in. So if we don't treat it properly, they are actually going to have so ascending infection, probably a necrotizing fasciitis. And then if the patient unfortunately has a CKD, they are going to have a worsening, and morbidity and mortality is going to be very high in this patient. So this is another major problem in Indian culture. Let's say patient with married women have toe rings, and you can see the problems in this patient where the first picture I can say that there is major constriction and the patient had a gangrene of the toe, where you can see that this is loose, but you can see there is some degree of friction between the first and the second toe because there is a subtle degree of hallux valgus. The third picture shows that the patient was asked to remove, but continuously end up wearing and having an suspected osteomyelitis in the leg. So this is another problem, but this is one of the example of a patient having a social, cultural activity which actually can have problem in. So you need to look at your population in your own way, that there could be another cultural thing which patient may follow, but it's important that whether it causes harmful to any of this thing we need to understand. So this is also to closer view of hallux valgus, where you can see that there is persistent rubbing of the second and third toe. And here you can see that it's another view of hallux valgus, and this is a bunion. This is all our own pictures where we've seen in our patients over the last 15 years. And when we talk about hammer or mallet toe, the very important, it is not that tip of the toe which is actually hammering here or hammering in the metatarsal phalangeal joint. It's actually on the dorsal aspect also. There is some degree of, if the patient is using a strap which is just cutting across the proximal phalanx or middle phalanx, then it is actually going to rub it in the dorsal aspect also, and the patient never going to feel any pain, and they end up having some degree of callosity and ulcer. This is a classical example. You can see that the patient he was using a narrow toe box because the patient had a habit of wearing a narrow toe box. So there is crowding of the toes, and you can see that because of the crowding, there is continuous pressure in the dorsal aspect, and the patient has a hammer toe, but dorsal aspect also has this. But the patient will never going to complain to us patient is having pain, and unless the patient has a sepsis, because then only we probably look at. But it's important to look at this carefully and probably give it some solution like strap modification, using a wide toe box or a normal shoe, so that it is not going to hurt, because this I'm probably explain it again and again. They are not having any pain. That's why they are doing, and they think what they write, but it's our duty to make sure that what they are wearing is not harming them and not causing major problem. So this is an example of how we make the strap modification and make it wider toe box. I mean, it is a slipper, so we cannot call it toe box, but it's actually a wider forefoot, and you can see that the strap was modified in such a way that it is not going to hurt. So I'm not going to the detail of it because sorry. You can see that there is a wide toe, and that gives enough space, and it is actually going to help in actually holding the foot in position, not in a crowded position. There are various insoles which is available in the market. Let's say India is a country with billion population, and obviously the Africa is also a bigger continent in terms of population, culture, social, etc. So it is not easy to provide footwear for everybody. So there are a lot of insoles which is actually available in the market. I will not say that you have to use this or this, but I would say that anything, if you have given a choice and if you're able to tell your patient what is the best footwear you can actually provide, it should be neither hard nor soft. That means it should be hard enough to prevent a nail passing through, and also should be soft enough to prevent any injury because of the foot wear. So the easiest way to use it, something called durometer, which is a small instrument where you can actually see the hardness of the sole. So if you look at the history of durometer, I don't have a picture of it, but you can Google a durometer, D-U-R-O-M-E-T, a durometer. It is actually used for the long distance lorry tires or a tempo traveler, to say that when they pass fast in the roads, they should be having an speed. That means their rubber in the tire should be so thick that nothing should go through. So they are using probably 100A of hardness, which is actually so thick that the nails or a thorn in the roads will not tear their tires. But what we are using here is just an abbreviated version where we're using a show value between 8 and 15. So I will not say which is good, because there are lots of materials are available all across the globe. But I would suggest saying that use one of that which is actually. So that means somebody may ask the question, do we need to give footwear for everybody? Yes. In patients with diabetes, if they have a chronic kidney disease, almost always, most of the patient will have certain degree of neuropathy. And most of our patient, especially if the patient is in, let's say almost all my patients have a habit of barefoot walking. So they're all at risk for some degree of foot ulcer. So by looking at the definition, this is all guidelines. It's not, though it is experience-based discussion I'm having, all I'm talking it is from the guidelines base, that what they mention is any patient who has a subtle degree of ulcer, deformity, past history of ulcer, you have to use a footwear. So that means in patient with diabetes and kidney disease, let's say almost always they'll have a diabetic kidney disease, mean they will have diabetic neuropathy. So because if they don't have neuropathy and if they have a kidney disease, then that means it's non-diabetic neuropathy, and we end up evaluating much and more, see that what is exactly happening. So, it is important to advise all your patients, but many times we may not be able to give the appropriate footwear. But I would suggest whatever footwear is available in the market with this show value of 8 to 10, 8 to 15 would be ideal for your patient. So let's say in the market, if we look at the current market, you can see every deformity you can actually treat. But I'm not going to say you have to give this, because this is to understand that every deformity can be actually taken care with so many gadgets. But remember, there's all these gadgets I'm just showing to say that we can have to treat, but really need not to be given. Because I'll tell you why we need not to be given. I will come into that subsequent slides, and I will be explaining it towards the end of my presentation. All these are available. Don't worry about where to use, how to use. I'm not trying to say which one to use, because this is to highlight that you can actually use every gadgets in this current marketing world, whereas actually the market is in our home, because the online marketing system is actually providing all this. What we are showing is actually bought in India from the online marketing platform. So what exactly the guideline says, if you have a patient with recurrent callosity, in spite of treating, or recurrent ulcers in spite of treating, or increased pressure. Let's say the increased pressure is not the easy measurement, because you need a good sensor plate, which probably you need to insert some lack of a dollar to have a good pressure plate to in our setup. So I would not go for the third one. Probably the best clinical decision should be with our clinical acuity, where there is a recurrent ulcer. So what we use in CMC Vellore is very straightforward. If you look at all the deformities, let's say malato, hamato, intertigos, bunion, everything is there in the forefoot, because that's where the pressure is more. So I'll be talking about anterior rocker a little later. Don't worry about, just keep in mind there is something called anterior rocker with 15 degree. But with that we give that, I'll show the anterior rocker in the next 10 minutes, and then we know what exactly is that. So when we give an anterior rocker, it actually elevates all the forefoot problems, and then if there is a callosity, recurrently we used to give that all this. But in my practice, I generally don't give for everyone. Maybe 1 in 1,000 I used to give, because most of the time they get away with anterior rocker, because as I mentioned, all these deformities are there in the forefoot, not in the hind foot, except fissures. Every abnormality or every deformity is there in the forefoot, not in the hind foot or midfoot. Unless they have a Charcot's foot, they have a midfoot. So by and large, I need to remember that all this gadgets has to be used with sock. So and many of our patients don't have their don't accept sock at least in Indian context, because most of the patients, men or women, never in the temperature of 45 degree today, nobody is going to take this gadgets in their feet. So just to highlight that this all are available, but this is not mandatory. You can always get away with a simple. So one of the other very, very important is that when I spoke to at least 4-5 professionals in Tanzania, they mentioned that most of the patients go to the religious places, stand outside and speak for an hours. And most of the patients, when I ask how do they speak, they said they left their footwear back home. Left their footwear outside the religious space, and they walk inside. So there are 2 types of sock, which is called, we used to call temple socks or mosque socks, where actually they can wear the sock, and one has an outer sole and one has an inner sole. So there will be one sole within the sock and one sole outside the sock. So when they walk, they actually walk with something outside and inside. So that means they are not actually really following a barefoot walking. When they go to the religious space, they're actually walking on a thin layer of some rubber or a silicone sticked in their sock. But this is not a footwear. This is actually a temple socks or a mosque sock, where they can wear. And if they have any of the deformity, and if they are going for any religious places, they can actually wear this. And one of the very good version is that some of the sock, as you can see that the left side, they have that outer sole, but some of the sock won't have an outer sole. They'll have only inner sole, which is made of silicone, and the sock is outside. So when they walk in the religious spaces, none of the people will tell that is actually some kind of rubber sticked outside. They think that it is actually a sock. So this helps in preventing a foot ulcer, because like let's say in Vellore, today the temperature was 45 degrees Celsius, which is almost more than 110 Fahrenheit. And then they go to the temple, they cannot walk inside the temple with their shoes. And if they have no sensory sensation, that means there is severe sensory neuropathy, they are going to walk with their barefoot, they end up having a foot ulcer. So that is going to cause major problem. If they have a chronic kidney disease in addition, if they have an infection, that's going to be a very serious problem. So it can always ask this to do that. So let's come to the second patient. You can see that they have severe neuropathy, and patient has past history of amputation. You can see this gentleman. This gentleman has the diabetes, no kidney disease, has other complication with proteinuria. And he has come. You can see that when they come for diabetes evaluation, they come and sit, and the patient never complained about his left foot problem, but you can see that there is an amputation. So when we closely looked at, he had a habit of barefoot walking in the temple. And when we closely looked up, he had actually a nice degree of some S-shaped, inverted S-shaped small hematoma. So when we removed, actually, he had a deep ulcer and it was not osteomyelitis. So this is another major problem. A callosity progressed into an hematoma within, and which is actually a major culture medium for an ulcer. Let's say third patient, a mild renal disease and a habit of barefoot walking. He had diabetes for 12 years. Presented with ulcer for 6. So this is a classical of how a patient with an amputation comes and just show the field. Because studies have proven that if a patient has an amputation in one leg, ipsilateral leg, they have 50% chance to get a second amputation in the ipsilateral foot as well as in the contralateral foot. My worry will be actually not the right foot, it will be the left foot. You can see that in the left foot, he has already started developing a hematoma here. If you can see the arrow. And also some degree of fissure is there in the greater toe, and there is fissure in the third toe also, and some subtle clawing in the other toes. So more than the right foot, it's actually the left foot is actually also started showing signs of high risk nature. So if we don't take care of this, so the patient is end up going to amputation, because as I mentioned that there is a 50% chance that second amputation can happen in the ipsilateral foot or the contralateral. So this is very, very important. So the worry is that how we are actually identifying all this problem. How are we actually going to offload? So let's say offloading, I'm started using offloading means offloading this part from the ground. That's what it says that. So there is a very beautiful guidelines which was laid down in 2019, actually, which has been recently changed in 2023. Not much of a major change, but at least it is actually now more clinical than in the past. So let's say another lady with 20-year-old barefoot walking with ulcer in the past has come. And this is the lady who has actually walked for diabetes evaluation. This lady has not come for any foot problem. When we looked at the feet, we can see there is a sausage in the third toe. You can see that this third toe is sausage, and there is second toe also. So in closer look, the left third toe was quite a bit of a sausage, and there is nothing, no discharge, nothing. So when you see a patient with any deformity, any foot ulcer, any kind of deviation from the normal phenomenon, always do an X-ray. This is the bottom line, because diabetes and foot ulcer, diabetes patient with kidney disease and foot ulcer, they're all same, but they're not same like patient with an osteomyelitis because of sickle cell disease or because of some other problems, because you can see that the terminal phalanx is totally eaten up, and there was a small callosity in the tip of the toe. When we removed it, there was a small sinus tract. And if you don't treat that at this moment, the patient is probably end up having an ascending infection some point of time, maybe an amputation or a prolonged hospital stay. So this lady was treated with antibiotics for 6 weeks, and the ulcer settled and no amputation. Somebody may be asking that probably osteomyelitis, the therapy is surgery. It is not always, almost always. Unless there is going to be a life-threatening problem, there is no need for an amputation. This is another testimony of how there can be a major confusion, because this lady has come for diabetes evaluation, no kidney disease, just come for a glycemic control. Glucose level was absolutely under good control. So it is we have a system that every year all our patients with diabetes will go for a foot examination. Every year it's mandatory. So part of it, the patient had a mandatory foot examination. The patient was found to have a nice bigger fissure in the greater toe, which is actually very unusual. The fissures almost always will be seen in the hind foot, but here the patient you can see in the forefoot. So every time when we see a foot ulcer, or the patient is coming for the first time, or we are seeing something for the first time, we always take a foot to do an X-ray. To a surprise, the patient had an osteomyelitis, which is actually ongoing. There were no sinus tract. What we saw was just a fissure. And when we looked at X-ray, there was a osteomyelitis, and this patient warrants an antibiotic. And if the patient is antibiotic, we empirically start with amoxicillin clavulanic acid. If the patient has come for the first time, if the patient is coming for repeated appointment, had a doctor shopping all across various hospitals with various antibiotics, we give probably gram-negative coverage. Otherwise, by and large, we give gram-positive coverage, and most of the time it's settled. And if they don't settle, we go for the surgery. This is another classical example of one patient where there was a callosity in the midfoot. And when this is a patient coming for the first time, we've not seen any degree of sinus or redness across. As a mandatory, we did an X-ray. We saw actually, you can see that there is loss of space, the joint space in the fourth toe, in the metatarsal phalangeal joint. You can see that it's lost, and it's actually an evolving septic arthritis. What we did was, we did an ultrasound and found there was a small collection. We were not able to aspirate because the collection was so small, we were not able to put a needle and aspirate. So we treated with antibiotic for 6 weeks orally. And if the patient has a high counts, we generally give IV antibiotic for a week and then continue for 6 weeks oral antibiotics, or even up to 8 weeks, and they usually. So this all are various way of osteomyelitis, where you can see there is small collection, and you can see here that there is no sinus tract, and we end up having an osteomyelitis in the first grade toe. So this is how, and sometimes it can be misleading, because many times we found a lot of foreign bodies when we remove the callosity. So it's very, very important to understand that that we look at the smaller things to prevent a foot ulcer, whether the patient have diabetes or whether they have a chronic kidney disease. It's almost same thing. There are a lot of classification to focus this, but I'm not going to detail of it. I'm just showing that a lot of classification. One thing I would like to highlight is all this classification, every classification I show, is actually one thing was missing. If they look at any classification for telling, let's say, University of Texas or Wagner's classification to identify the depth of the infection, they never talk about the renal parameter, because all the guidelines, all the prevalence study, and all the studies which looks at the morbidity and mortality talks about renal problem as the biggest problem and mortality and morbidity in the foot ulcer. But till date, there is no classification which is actually included renal disease as a 1 point. Even the Sindbad, which is being used all across the globe, did not incorporate the renal disease as a point. But if you look at the any article which has an endpoint as a death, the renal parameters is the biggest one. But probably one of us should take as a project and say how to incorporate a renal disease into the system. So when we talk about diabetic foot, it could be having a severe infection, moderate infection, mild infection, and uninfected. But what I'm going to focus is only on uninfected, because mild, moderate, severe needs antibiotic or debridement. But what we see in our day-to-day practice is not the mild, moderate, or severe infection, because they all have some degree of fever, redness, or warmth, or some degree of signs of inflammation. What I'm going to focus is only on to my left, which is an uninfected foot. That is what is the biggest chunk of patients which we see in our OPDs. So what I'm going to talk is only the offloading. I won't talk about antibiotics and debridement. I'll talk about only offloading and close my talk, because I'm just going to highlight that there are lots and lots of information in terms of preventing a foot ulcer in a primary prevention, as a secondary prevention. The tertiary means had an amputation as a rehabilitation. What I'm going to talk is a blend of primary prevention and the secondary prevention. If you look at the guidelines, the Western guidelines talks about offloading in a little different way than what we actually use in our practice, especially in an Indian context. The names we use are actually a little different from the guidelines, but when we actually stitch it together, it is actually the same thing what we are talking, but the end results is the same. But what we are actually, how we are tuning the footwear in terms of naming is slightly different. Otherwise, all are actually focused on the same. when we call it as offloading, there are two types of offloading. One is complete offloading. That means the patient is never going to keep their foot down. That means, let's say, wheelchair, walker, crutches, total contact cause, eye walker, all these are actually a complete offloading, where actually the foot is off the ground, 100% off the ground. Let's say half shoes, clogs, insole reliefs, they have actually a partly offloaded. That means either only the forefoot is offloaded or hindfoot. So there are something called two offloading, when it's complete offloading and other is partial offloading. If the patient is having foot ulcer and you make them lie down continuously all across all 24 hours, it is called complete offloading. If the patient is walking with a walker, it is completely offloading because the patient is off the ground. Suppose you are using half shoes, then I'll be coming to what exactly half shoes. So in 2019, there are multiple guidelines, but 2019 is the best guideline I have actually ever come across. It has been modified to 2023. But I'm going to talk a little bit of, I'm just highlighting what exactly they talk. So what they tell us, any patient walk across to you with an uninfected foot, and you find an uninfected foot, you put everybody casting with a plaster of Paris. I am sure in an African setup, an Indian setup, it is not possible to put everybody. Let's say you have a gentleman with foot ulcer, which is around 2 centimeters in the forefoot. You put a cast and treat them. That's what they tell. But in our context, with the number of population and amount of population, amount of patients, we are not able to do that. So this is called, this is what the Paul brand has exactly invented almost 4-5 decades back. It is called total contact cause, where it's actually put a plaster of Paris with a rubber piece outside, and you can see this is a classical testimonial of how the TC is being put, and this is another patient where they're having a hind foot ulcer, and you put a TCC with a small window. We put window. The reason is that our patients are almost always apprehension about the ulcer not being shown to them. So we always put a window and show the patient this is how it is, and put a rubber outside. It actually gives complete offloading for all our patients. But remember that this needs expertise and this needs patient compliance, because they have to be here for 6 to 12 weeks at least sometimes. And with the amount of patient load, amount of diabetes all across Asian and even African population, some of the countries has higher prevalence of diabetes. You can't use it because, and especially if there is a chronic kidney disease, they have neuropathy, and they can have some degree of foot ulcer, smaller, even 0.5 centimeter ulcer. You can't use it. But the 2019 guidelines say use a knee-high offloading device. Let's say knee-high offloading devices, a footwear which actually goes up to the knee joint. But in 2023, they changed the guideline saying that they can use a footwear which is up to knee joint or up to ankle joint. So this is a footwear they are talking. It's impossible to make in any part of world unless they have an expertise. This is not an easy job. This is made in CMC Vellore. So CMC Vellore has a good orthotic center, so that's why. So this is another example of what exactly is the offloading device. I'm just showing the pictures to say that this whole area is a major thing to understand and take it further, but this all cannot be made. But what we can make is the one which I'm showing in the picture. This is called anterior rocker, but the guidelines say it is a half shoe. It is half shoe because you can see the forefoot part is elevated. So this can be easily made by anywhere footwear shop, because all our footwears what we are using has a 4 to 5 degree of rocker. And this is an anterior rocker is a 15 degree. This is what I mentioned. If you have a patient with no foot ulcer, all the patient will have a hammer toe or mallet toe, will have a clawing in the forefoot. So when they elevate it little more, they are off the ground and they end to having a lesser foot ulcer. This is what happens. So the patient comes with an anterior foot ulcer, which is a greater toe. You provide an anterior rocker. You can see in the right side, it is healed over around 7 to 8 weeks, and the patient continues to use it because the patient has a subtle clawing the anterior foot, or let's say forefoot, and they have to use an anterior rocker with a 15 degree. 95% of the patient in our population will have forefoot ulcer only, not the midfoot ulcer. So if any of your patient with diabetic kidney disease have clawing or mallet toe or hammer toe or intitygos or bunion, you can use this anterior rocker with 15 degree, and it is very easy to make in any setup if you have an orthotic person. Or now in India, in online marketing forum, we can very easily get this. So I'm not sure about the African region. You can always explore that. This is another patient with bilateral foot ulcer where you can see that. So what we call it is actually a little more elevated. There we used to have 15 degree elevation, where this is called ortho wedge, where you actually can see a little more elevated forefoot, where the pressure is not accepted. This is nothing called again half shoes in the guidelines, but in this is same word is being used in African countries also of anterior ortho wedge. So this you can see the before and after, where the ulcer is actually healed completely after using. When we use ortho wedge and when we use in where rocker is simple, when the ulcer is small, we use anterior rocker. When the ulcer is big, we use wedge. So this is the difference, where you can see the left side is the wedge and the right side is the rocker. So then in our mission hospitals, where in CMC has a lot of mission hospitals they run, where actually it is not possible to make anterior rocker. In that case, what we can use it something called a metatarsal bar. So let's say I mentioned almost always 95% of patients with diabetes or diabetic kidney disease have their problem in the forefoot. So what you do is take a piece of rubber, put a glue and stick it outside. That's it. It acts as an anterior rocker. So the simple footwear from the market, get it, ask your person who makes footwear, or even where the patient is getting the footwear, simple modification is also well and good if there is limited resources. But remember that we shouldn't put it in the inner aspect, because the patient can have neuropathy. So when they have with inside the footwear, it is actually causing more problem. Suppose the patient has a flat foot. The flat foot again is going to cause anterior foot problems. So it's important to elevate with the medial arch support. Let's say the patient is having ulcer in the hind foot. Let's say having an fissure. If the patient is having fissure, we need not give this device. If the patient is having a fissure and an ulcer, then we usually give this, which is nothing again but a half shoes, which is there in the guidelines. Okay. So the 2023, the guidelines has been changed in such a way that we can use any of the modalities or of forefoot offloading shoes to prevent a pre-ulcer as well as ulcer which is not infected. If there is an infection, the patient has to go for a debridement surgery, and then you can provide all this footwears. This is one of the famous offloading called felted foam, though it has a very limited healing capacity, but in many African countries, I've seen using felted foam and then put a small scoop in the area and put a bandage so that it acts as a offloading thing if the patient is having a foot ulcer and not infected. So there are a lot of different dressings. It's all to understand that it all talks in the same tune. There is no difference. It is by using sponge or using small cotton and make it in the metatarsal bar kind of. And if you don't have anything to offer, let's say the patient is not buying the footwear, then you can use all this maneuver. But remember that it's not going to have greater use, but to a certain extent you can use it as a reserve modality to use. But if you want to use offloading, let's say the patient is going for dialysis and patient is not going to walk around, patient is in sepsis, the best is if your patient is conscious and you can use a wheelchair or crutches, or bed rest is the best, because patient is not going to put their feet down and it's going to heal that. So that in terms of patient who is bedridden. So putting across, this is one of the algorithm which we made in our institute, other than the one which I showed initially for the pre-ulcer state, where all the patient with pre-ulcer, clawing, malato, hamato, you can actually use an anterior rocker and get away with that. It's simple. Unless there is a fissure, you give some 6% salicylic acid in the fissure and the fissure will closes, and then they have to take care of their foot. Suppose, let's say a patient is coming to you, have a diabetic kidney disease, has a foot ulcer which is uninfected. Let's say uninfected. It's not an infected. If it's infected, you need a surgical colleague or a vascular surgery colleague to take some actions. If the patient is having an ulcer in the forefoot, 95% of patients are going to be falling in this category. So you can use any of them. I've shown a lot of pictures, ortho wedge, anterior rocker, everything can be used, but it has to be used wisely. Let's say if it is less than 3 centimeter, just towards the forefoot, you can use anterior rocker. If it is 3 to 5 centimeter, then you have to give an ortho wedge. If the patient is accepting TCC, that's the best. But remember that TCC is not the solution because it needs an expertise and not an easy work to do. The midfoot is very small number, let's say around 3% only will have midfoot. Most of the patient will fall into this category. If there is midfoot, it needs a lot of expertise. You need a surgical colleague and a PMR physician to help. But if you have a support system, the best way is put to total contact cost. TCC is nothing but total contact cost and get away. Hindfoot, again, I mentioned that you can use half shoes, which is nothing called posterior rocker. But if you have a facility to put a total contact cost, you can use it. What I talked is plantar ulcers. Now let's say dorsal aspect of the ulcer. That means it's in the top of the foot. You can use surgical shoes and get away with that. And Charcots, I'm not going to touch at all because this is a major problem in terms of loss of architecture, lots of proprioception, all the arches are collapsed, and so it is much more, but I'll just highlight. When a patient comes with Charcots without ulcer, we look at the ankle joint. If the ankle joint is stable, that means the ankle is okay, talar and subtalar joints are fine, and talonavicular joints, everything is fine. Then we put a molded insole and need not stabilize the ankle joint. If the patient has no ulcer and the ankle joint is gone, then we have to put a special footwear which needs a lot of expertise. And remember that this is actually a multi-departmental teamwork, not a single person involved. We have a bigger team, and this team has evolved over the last 2 to 2.5 decades. It's not over a weekend or over a year or a couple of years. All this, whatever I showed, is actually a work of multiple people sitting behind my scenes and probably sleeping in the night right now. They all have their role in that, and whatever I show is actually all the pictures being taken from a center and win. So thanks for patient listening. And this is one of the part of the team which I've shown, that is all of people who are highly specialized in foot care and footwear, and they are doing their job behind the scenes quietly. And you can see the left side is the institution and the right side is our manufacturing area where they manufacture all the footwears, offloading devices, etc. And thanks for patient listening. And you can watch all the offloading videos in this video YouTube channel which we have put. You can actually watch it because all the offloading devices are shown much more greater detail to understand how it has been used. So thanks for the patient listening, and go to the organizers and we can have a discussion start on. Thank you.
So thank you very much, Dr. Felix. This was a very elaborate presentation, and also it's really nice to see that you have a really elaborate foot care program in your hospital. We would invite questions for Dr. Felix through the general chat box or the Q&A chat box. However, if any of the attendees do wish to ask a question in person, please do raise your hand and we will unmute you. For the panelists, again, please feel free to unmute yourselves and ask a question to Dr. Felix directly. As we await questions, we will have this chat uploaded on a video through YouTube by the weekend. So hopefully you can visit our page, Africa Healthcare Network Fireside Chats, on YouTube and have access to this video and the other 100 videos that we have done over the last 2 years for your viewing. Probably, Dr. Felix, I would set the ball rolling by asking, have you ever seen any calciphylaxis as far as foot ulcers is concerned the calcific uremic arteriolopathy?
Yes, very common. If the patient has chronic kidney disease for quite some time, we have seen, but most of the patient, when they have calcific acid, they end up having an amputation because they have the consequences of that. And almost always they end up having, if there is a foot ulcer and calcific access, it's not going to be easy. They have a poor blood supply and subsequently end up having amputation.
And would you comment on the use of peripheral vasodilators again in the use of foot ulcer management through your experience?
No, the evidence behind fentoxifylline and the other agents is not being advised, because the let's say the prevention of amputation is not higher when we use that. Probably the aspirin and clopidogrel has a subtle edge, but otherwise there is not much of a role for our fentoxifylline or silastazole.
Dr. Lloyd, please unmute yourself.
Dr. Felix, thank you for this wonderful session, and there's so much that really to learn, because we are so focused on the kidney and we never look at the feet, and this is really an eye-opener. Now, in terms of quite a lot of these patients, because of this ulcer, I see land up in vascular surgery, and a lot of these vascular surgery people, especially those who do interventions, they either do surgery or they do angioplasty. So what is the role of these, angioplasties or, surgical bypasses in these sort of foot ulcers?
Yeah, thanks for the wonderful question. It's very straight. If there is a good blood supply, there is no need for any angioplasty or no bypass. Let's say the ABPI is more than 0.8. or less than 0.3, 1.3, that is nothing. If it's more than 1.3 ABPI, that means probably having an arteriosclerosis, and it's not going to cure with any of the maneuvers. Let's have a critical limb ischemia less than 0.5 with a toe pressure of less than 30 or 40 millimeter. Then the vascular surge intervention is going to help. Unless there is a critical limb ischemia or a life-threatening gangrene, there is no role for a vascular surgery intervention. That's what we strictly follow, and it's very straightforward. We look at the we call it as inspection and palpation in the foot. Inspect the foot, look for a peripheral artery sign, palpate with your hands and palpate with the ABPI Doppler, and take the decision. So we refer only if there is a vascular compromise with our simple ABPI. That means ankle brachial pressure index.
The other question is, if you have fissures, on the leg, these fissures, do you do posterior offloading, or what do you do with them?
Simple fissure, no need for an offloading. What we give is called heel counter. Footwear is because all the patients are exposed to the sun when they walk and have a dryness. So if there is a fissure, no need for an offloading. They just need to take care of their feet and give 6% or 12% salicylic acid. If the patient has a very thick skin, 12% salicylic acid. If there is a thin skin, 6% salicylic acid. Footwear with a heel counter. Suppose the patient has an ulcer in the posterior part, which is less than 5% by prevalence itself. Then we can give a offloading if the ulcer is in the plantar aspect. The ulcer is in the Achilles tendon region. The heel counter is going to take care of that. What we do is give an extra cushion in the ulcer area so that there is no contact between the heel counter. So heel counter is the must if there is a fissure to prevent exposure to the atmospheric air.
When you say heel counter, that means what is heel counter?
Cover the posterior part of the foot. It's like shoes.
Okay. And so barefoot should be avoided at all costs in all diabetics. That's the rule.
Pardon?
Barefoot walking should be avoided in all diabetics.
Yes. Yeah, all 100%. No barefoot walking. Moment they get diabetes, the barefoot walking should be avoided.
So we have a question in the chat box from Dr. Akrabi. I believe more clarification is needed on the offloading technique, Dr. Felix.
See, offloading is an English word that where you off the ground. Let's say I have an ulcer in my forearm now, and I'm not going to touch that ulcer continuously for next 10 days and see whether it heals or not. Because the moment I touch, I have pain and I won't touch it. So I keep the ulcer away from my foreign body or away from anything which can hit. Similarly, when the patient has an ulcer, let's say this is the feet, and when they have an ulcer in the forefoot, so I need to offload from the ground. But unfortunately, they don't have pain, so they walk with the ulcer continuously and walk with their barefoot in spite of having an ulcer. So what is offloading is offloading their foot from the ground. What I said is all these ulcers are there in the forefoot. So you offload with an anterior rocker from there. So offloading is nothing but offloading the feet from the ground with some modification in the shoes. I hope I am able to explain what exactly the offloading is in a very simple English.
Thank you. Dr. Akrabi, sorry, Dr. Lloyd. Dr. Akrabi, if you need more of a clarification, I am going to unmute you. And you can just unmute yourself and ask the question if you need to further. Sorry, Dr. Lloyd, please proceed.
All patients with a foot ulcer needs offloading. Am I right?
Yes, because the pressure exerted from the body to the foot is through that, because when we walk, we have a toe, then we put the heel, then toe, put the heel, then toe. We have something rocking movement in the feet. So that means if the ulcer is in the forefoot, we stamp, that ulcer is not going to heal. Then there is a distortion in the epithelium. It is continuously stamping either in the forward foot or hind foot. So when we elevate the anterior rocker, that when they walk, that particular forefoot is actually offloaded with the exaggerated octara. If we look at all our shoes, there will be a subtle degree of rocker, and the traditional any shoes from the market have a subtle degree of rocker, which is around 4 degrees. We are exaggerating to 12 degrees to 15 degrees. So when they walk, that part is offloaded. So it is like that's why I mentioned any ulcer in my hand, I will make sure that it won't touch my shirt or touch the foreign body anywhere nearby. So this is a simple same analogy. Offload any ulcer. So, but remember, we need to understand all the prevalence of foot ulcer. 95% of the foot ulcer is there in the forefoot, not in the hind foot and not in the midfoot. That holds around 5%. So a simple anterior rocker will actually get away in simple terms. That's a garden variety of foot ulcer.
So when you say rocker, that means the foot is elevated on the front. I mean, anterior rocker, it means the foot is kept by the footwear, keeps the foot elevated, not allowing pressure.
Yes. So I can show. Yeah, this is the one.
Yes.
Yeah. So it is elevated. When they walk, they probably, the pressure might get away from here, which with the pivot is 65%, that let's say it ulcer is in this forefoot. When they walk, the rocking will go off. So they end up transmitting lesser pressure.
So all diabetics need footwear. And all those who have a clawfoot or any other deformity, a rocker will always help. And if there is an ulcer, always you need to actually have make sure that the foot is elevated, and the term used there is offloading.
Yeah, offloading anterior rocker, but the guidelines says as a forefoot offloading shoes or half shoes. That's what they put it in the guideline, but nothing but this is the local terms which we use, and even in Africa the same. When I met people there, they use the same words. They don't use half shoes, they use rockers.
Dr. Felix, I think Dr. Akrabi is still seeking more clarification. I think you did share a slide on this, but the question is again, for how long is offloading needed until the ulcer has healed, or maybe for a longer time?
See, all this patient with an anterior foot ulcer, the moment they have the ulcer healed, you can give a normal footwear that is straight. But if they have deformity, let's say clawing, mallet toe, hammer toe, then they have to continuously use their anterior rocker. So I'll show one slide of that to clarify. I'm sorry, I'm taking a little longer time to show this.
Thank you.
So all the deformities, if they have, you're giving to give anterior rocker, then they have to continuously use their rocker. One, suppose the patient is having only foot ulcer and no deformity, then when actually go back to the heel counter and backstop with or without anterior rocker. The without is depends upon long term is depend upon the deformities. If they have deformity in their forefoot, they continues to use their anterior rocker. If the patient has no deformities, has only one plantar foot ulcer which is in the forefoot, they can actually go back to their footwear. I would say that definitely heel counter without anterior rocker if there is no deformity. If there is deformity, they have to continuously use that anterior rocker. Let's say this 15-degree anterior rocker is not a bigger elevation. If there is, I mean, if you can see, if you see the footwear, it's not a bigger elevation.
Is it prophylactic to give an elderly diabetic a rocker to prevent?
If there is deformity, yes. If there is no deformity, a simple footwear is fine. But there also, I would actually probably look at this way. If that gentleman or woman is not moving around much inside their house or outside their house, he is probably 70 or 80-year-old man who walks, probably use their restrooms. But if there is a still deformity, I would probably give a simple footwear. The reason is that they're not going to use their footwear and tap the foot continuously in the leg and probably get an ulcer. So if the mobility is very much less, let's say Parkinson's disease, patient is on dialysis, all this, even if there is a deformity, you can actually use a simple footwear. But if there is a, let's say 80-year-old man who is active, walks around 2-3 kilometers per day, very active, has deformity, probably anterior rocker should be. So it is a slight case to case basis, but simple equation would be any deformity, anterior rocker, no deformity, simple footwear.
Dr. Felix, we have a question from Dr. Anthony Giunda. He's from Tanzania, consultant nephrologist. Dr. Giunda, please unmute yourself.
Okay, thank you very much, moderator, for this chance. First of all, I congratulate very much the presenter for the very important topic he has presented today. I have one question, because one of the most common cause of diabetic foot ulcers are the fungal infection between the toes. This is what we call, athlete's foot. So I just wanted to know from him, his experience, what is the protocol of caring these infections, or even preventing them? Because most of the time we find these diabetic patients having some fungal infections between the toes, and these would be very serious, sometimes leading to DFUs and ending sometimes to amputations. What is the experience from his side, whether you have to give some preventive or antifungals, or how do you care to prevent the infection?
Yeah, thank you, Dr. Anthony, for the wonderful question. Very common in Indian setup. This is one of the patient's picture. You can see there is fungal infection between the toes. The best is to ask your patient to look at the toes daily like their face. That's what we tell in our diabetic clinic. If you feel your face is important, if you're looking at your face in your glasses, use the same glass to look at your feet in the anterior aspect and the posterior. Let's say, in other words, dorsal aspect and the plantar aspect, and inspect the feet every day, inspect the web space of the feet every day, and clean it, and use warm water to clean and wipe it with a cotton towel. This is what we tell to every patient. As a physicians and the nephrologists, it's our duty to look at their toes, wipe space of the toe, because that will be the very common, especially in Indian setup as well as in Africans, where the temperature can be so high. It has to be seen, and there is no prophylaxis. But if there is infection, you have to give an antifungal, let's say cotrimoxazole cream that's more than enough. If that is not able to, then you can fusidic acid or something to provide that. Simple, let's say we in our we call it candid cream. It's very commonly easily available across the, this is nothing but a co-trimestral cream. But that is the, if you ask a primary prevention, it is patient education to look at their web space and clean it daily. Very, very common.
Okay, thank you very much.
So we have one more question. I know we are overboard with time, but just one comment rather from Dr. Jacqueline Shaw. She's a senior nephrologist from Tanzania. That she's sharing her experience that she's seen patients with foot ulcers for more than 3 years. And one of them wears strap sandals, and our diabetologists here would need to look into these shoes that you have shown us to save our patients. So thank you for the comment, Dr. Shaw. And I hope you wouldn't mind taking some more questions by email in the coming days from our end, if anybody is seeking more clarifications, Dr. Felix.
Yes, happy to respond to the emails.
Thank you very much. I would like to thank everyone for attending this evening's chat, but it's very late in India, and I'm very sure Dr. Felix would like to call it a day. I would just request all the Tanzanian attendees to use the link posted by Dr. David in the chat box for claiming CPT points. This is only for Tanzania. And also, again, we will have this video uploaded on YouTube in a couple of days' time, and hopefully you will all join in and view the video and share the links, of course. I would like to thank once again Dr. Felix Jebasingh, and I would like to request Dr. Lloyd for the closing remark.
Thank you very much, Dr. Felix. It was a wonderful session. A lot of it was terminologies that honestly, I have not heard. Probably because we are ignorant of the whole fact and we don't look at the legs. And it's a very, very important aspect because, yeah, as you mentioned rightly, CKD and foot ulcers, infected foot ulcers increases mortality, and infection is the second leading cause of mortality in patients with CKD. So this is an extremely important topic, offloading the footwear. All diabetics need footwear. Offloading is important, especially when there are anterior deformities, and I think that itself would cover a very large percentage of patients who would land up in problems. So extremely grateful, Dr. Anthony, and I mean Dr. Felix, and this will be put up on YouTube, and I'm sure a lot of people will benefit from this knowledge that has come up. Thank you very, very much, and I'm sure it's very late, and we've kept you up. Extremely grateful for giving us your valuable time after a long day's work, actually. Thank you.
Pleasure to be here, and thank you so much.